Us today for this virtual press conference about a new bill, new bipartisan proposed bill that would help people who have diabetes be more able to afford their treatment. Last year we passed HB 4543. After a trip to Canada, many people that are in the audience here went to Canada with us. We visited Niagara Falls and we bought insulin more cheaply. And then we were thrilled when the legislature responded and passed HB 4543, which puts a cap of $100 on insulin purchases that are covered by policies that the state is allowed to cover. Federally covered policies are covered by federal law. This bill that we will be introducing does a couple of things. One, importantly, it creates a copay limit for equipment and supplies that are used by diabetics. Two, it would lower the copay for insulin to $25. And three, it would create a new copay for non-insulin medications that diabetics need. So I'm going to briefly introduce our speakers. We have a lot of them. And maybe when I say your name and a little bit about you, if you would wave, and then people can identify you. The other thing is, if you are in the media and you have questions, would you please put them in the chat so we can be a little bit more efficient. Each of our speakers is just going to be on for a couple of minutes, and we will take all questions at the end. Our speakers are in this order: Matthew Rohrbach. He is a physician and House of Delegates member from Cabell County. He serves on the Health Committee and the Finance Committee, and he is a Republican. He is going to co-sponsor this bill, be one of the sponsors. Next is Anders Lennerhog. He is a licensed dietitian and a longtime type 1 diabetic. Alan Hawkins will also be joining us. He is a retired pharmacist and diabetes educator, also type 1. After Alan will be Adrienne Kiger Olmstead. She's a middle and high school teacher. She is a type 1 diabetic since she was 11. Jeanette Rousey is an accredited PR consultant who focuses on children and mental health. Maggie Ryder is a middle school teacher and mother of a type 1 diabetic who was since he was in kindergarten. And last, our cleanup hitter is going to be Gary Doherty. He is with the American Diabetes Association. He's Director of State Government Affairs. And I am happy to say that I'm associated with this group of people and this project. And I want to start out with just a story. When I was in college, my roommate told us that, my roommate worked at a camp for diabetics and children. And I will never forget her telling me that all of the kids died when they were teenagers. They dropped off because that was the state of affairs. And that is showing my age a little bit. When I was growing up, there have been some tremendous improvements in treatment for the diabetics, but some of them for diabetic patients, but some of them are very expensive. So I'm going to turn it over to Matt Rohrbach, who's going to tell a little bit about the medical situation and also about the financial situation associated with these medications and these types of equipment and supplies.
Thank you, Barbara, and it's a pleasure to be here today, and good afternoon to everyone, and thank you for your attendance. As Barbara said, last year we were able to pass House Bill 4543, which was an important first step. But I guess I'm going to go at it from two angles. Obviously, my day job is I'm a physician here in Huntington. I don't directly treat diabetes. I treat some of this long-term end organ damage of diabetes. But I'm not an endocrinologist, I'm a gastroenterologist. And then I'm going to talk a little bit about the legislative aspects of why this bill last year was so important. And this bill looks to build upon that. I'd like to start out by reminding anybody that doesn't already know, I'm afraid you all do already know, that we lead the nation in the rate of diabetes. Any study you look at, we're always in the top 5. It's unfortunate, but that's where we're at. Now, what we did last year was put a limit on the copays for insulin. But where we need to go further is on the technology. There's really been tremendous improvements. And I'll tell my age a little bit as well as Barbara told hers. And, you know, when I was a young medical student, we still had pork insulin, and that was it. And now we've got different forms of insulin. We've got a tremendous amount more oral medications, and we've got continuous glucose monitors, so that we've really advanced a tremendous amount. But unfortunately, a lot of people don't have access to this because of the cost. Now, you say, well, why is this really important? Because, you know, the long-term consequences of diabetes, the end organ damage, the heart attacks, the heart failure, the strokes, the peripheral vascular disease, renal failure, and on and on and on. We can prevent a tremendous amount of that with better diabetic control. And we now have the technology and the medications in place to accomplish that. So what this bill is really an attempt to do is to make it easier for individuals to get access to these life-saving medications and technologies, and also at the same time really limit the effects down the road of all the end organ damage from diabetes. And it's kind of like the old Midas muffler commercial. You can pay me now or you can pay me later. We can spend our money now and really improve the diabetic control in our population. And down the road, we'll have tremendously less problems. So I would urge people to consider this legislation. I think it's very helpful, and I'm happy to co-sponsor this with Barbara.
Okay, our next speaker is Anders Lennerhog.
Yeah, my name is Anders. Mostly I've worked as a registered dietitian in a clinic in clinical nutrition and geriatrics. And I have seen a lot of people with diabetes, especially type 2 with amputations and so on, and heart disease and strokes, like the doctor said. So that's very common. I'm not really an expert on pumps, I don't think, but I have a pump. And I think everybody should have a pump. Everybody that can handle a pump should have one. I think you can have a pump down to 2 years of age, approximately. But anyway, continuous glucose monitoring is sort of what I have. It's, my sister has a different pump, and that measures blood sugar continuously, sends it to the pump. The pump can actually decrease the insulin or increase the insulin depending, and it can give a warning when it's high and low. Mine doesn't do that. I can show you what I have. I have an Omnipod pump, looks like this, and I have a glucose monitor looking like this. And all I do is push the button and go like this. I have a little thing up here. And it's just a tiny little needle into the interstitial fluid that measures the sugar level. Usually it's about 5-10 minutes behind if you do a blood test.
Show me your pump.
Yeah, she says, so show the 5. This is my insulin pump. I like that one because I can put it up on my arm. You can't do that when you have a hose attached to it. So what I can do, I check my blood sugar and I get these numbers like this. And it tells you if you're going up or down or if you're steady and so on. So I can adjust all the time. I have a diabetes nurse in Sweden. She said you have to test at least 20 times a day. That's a minimum. So when you do that, you can really fine adjust. I can give 0.05 units at a time with this pump. Can't do that with syringes. And you can't do finger sticks 20 plus times a day. So that doesn't work. So you have different kind of sensors. You have Dexcom or Dexcom, slightly different than this. That's continuously talking to the pump too, which mine isn't. The thing though is my hemoglobin A1C was a bit over 10 before I got the sensor, and it dropped to about 7 in a couple of months. So that really helps. I've had diabetes for 37 years now. So my father had it, my sister, my niece has diabetes. So I don't know. The insulins you use for the pumps are the fast-acting insulins, Humalog, Novolog. Sanofi has one also called Lispro, and I've used all of them. They work fine in the pump, no problem there. Here I'm using Novolog. The problem with these things, I think, is the cost for it. And in Sweden, it doesn't cost anything. We have a different system. So usually when I go there, I get a bunch of everything and I come back here. So that works. But this sensor lasts for 2 weeks, and then you changed it. So I get 2 per month, and it's $121 for that.
After insurance.
After insurance, yeah, right. So it is expensive, and it's going to be difficult for people to afford these things. So if we can lower the prices on these things, that would be great. But I really recommend these things. I recommend the pump, and I recommend these sensors.
Can I say something?
Ann wants to say something.
Sorry, I've been married to Andrews since long before he had a pump, and I got to tell you something. He's a lot easier to deal with on the pump. So it probably will save a lot of marriages.
And live.
You know, rather than having his blood sugar go from extremes.
Yeah, the hemoglobin A1C can often look fairly good, but you can do that because you've had low blood sugars also. That happens.
Yeah. We have to move along. Our next speaker is Alan Hawkins. Do you want to share your story, Alan?
Sure, I'd be glad to. Can everyone see me?
Yes.
Okay.
Thanks,
Now-
Andrew.
I'm a pharmacist, diabetic educator. I've been a diabetic since I was 10 years old, and I'm 73. That's 63 years. Now, I want to tell you that how you treat diabetes is with technology, knowledge, and a good health team. I've had all those things. I have Medicare and I have Humana, excellent insurance. Not everyone has that, but I'll tell you, I've lived 63 years with no major complications to my diabetes. And why is that? Because I've learned about what it takes to do that. And one is the money to pay for it, for insulin, for the pump supplies, for everything he talked about. I do have the latest pump. This pump, I don't know if you can see it very well, but every 5 minutes or 270 some times a day, it tells me what my blood sugar is. He was talking about him. And so that pump then tells my sensor, which he has, I have the Dexcom sensor, it tells the pump how to make adjustments in my insulin automatically. So it's like your pancreas. When you go out and work in the yard or do something, you need less insulin. Your pancreas stops producing insulin. This pump has helped me beyond compare. I cannot imagine being without it, especially at 73 years of age, because you have other things wrong with you, and this makes handling those better. The cost of this pump in my supplies, I have insurance. The cost the insurance company actually reimburses is over $16,680 a year. That's in the United States. My insurance, Medicare pays 80% of the price of this after I meet the deductible, which is about, I don't know, $500. And then Humana, after I meet their deductible, is about $150, pays 80% of it. So for about $650 a year, I get $16,800 worth of diabetic supplies. I think that's wonderful. I'm the exception, but I am the example. I've lived 63 years with type 1 diabetes, from time which was horrible to take care of to a time which, exactly what gentleman before says, will change lives, will increase cost. Now, my $16,000, you asked me the other day about the cost of the pump. The pump is $5,256. And for 13 months, my insurance will pay $475. After that, my cost will go down by over $5,000 a year. So that brings me around to $12,000 for my supplies and my insulin. I think that's fantastic. So what we need is for those people who have insurance to have co-pays in line so they can live 63 years with diabetes too without complications. It has not been easy, because he was right. You know, testing your blood sugar 10 to 15 times a day by sticking yourself a finger is not, you still have a dumb pump. You still have to make the choices on your own. This pump is the first step in towards an artificial pancreas. It's wonderful. It's changed my life. And I want to be there to help people in passing legislation that will make this happen for a lot of people.
Thank you so much, Alan. Our next speaker is Adrian Kiger Olmsted. Adrian, why don't you share your story?
Hi there. I have lived with diabetes for 35 years. I was diagnosed at age 11, and I went off of my parents' insurance when I was 24 years old. And since then, I have paid an upwards of $250,000 for a combination of insulin, supplies, and insurance over the years. It's a lot. And managing blood sugars is difficult enough. You know, as Alan said, we are trying to mimic a pancreas with our insulin. That is extremely tricky to do, and we do it every day. And you couple that with the struggle to afford insulin and the higher end supplies that will help manage the blood sugar, and it just feels discriminatory that not everyone can afford this kind of care. And every diabetic deserves the opportunity to have controlled blood sugars so that we can live long and healthy lives.
Thank you so much. Our next speaker is Jeanette Rousey.
Thank you. I'm going to just present some screenshots. Hopefully my screen share will work and give you a sense of the big picture of where we are in West Virginia. I've gathered some stats from the CDC, American Diabetes Association. So let's give this a try.
And Jeanette, while you do that, I neglected to say that our bill is modeled on legislation that passed in Connecticut. And so some of the statistics that Jeanette will be showing are from our state and from Connecticut. But they passed a bill just like this in August. And that's when we thought, if Connecticut can do it, why can't West Virginia?
Thank you. I'm apparently having some technical issues with my computer sharing my screen, but I can share some numbers with you, and then I'll post them to our Facebook page for the West Virginia Team for Affordable Insulin. And there's a link and there's a graphic that I've put together that might be helpful for you. First of all, again, as Barbara mentioned, she and Dr. Rohrbach have been inspired by legislation that was put together by the General Assembly of Connecticut, the equivalent of our legislature. Connecticut happens to be the state with the lowest ranked diabetes mortality. We have, just to give you some numbers, which again, I'll share on the graphic later, individual median income in Connecticut is almost $38,000 per year, compared to about $25,000 for West Virginians. So, you know, purchasing power is much lower here. In Connecticut, about 11.3%, these are based on 2014 numbers, 11.3% of the adult population is diagnosed with diabetes or is estimated to have diabetes. That's compared to 15.3% in West Virginia. Approximately 256,000 people in West Virginia have diabetes. This is the adult population only. And a number that I think should concern all of us, that again, where Connecticut has the highest, well, the lowest mortality rate, so, obviously the best outcomes, diabetes is still the 8th leading cause of death in Connecticut, with 14.6 deaths per 1,000. Compare that to West Virginia, where we have 36.2 deaths per 100,000. These are per 100,000. In 2018, that was 927 West Virginians who died. So, this is a very serious matter. And in West Virginia, it's the 6th leading cause of death after heart disease, strokes, and some of other, major causes of death. But when we look at, what are we doing in West Virginia to increase access, just like Anders and Alan and Adrian and some of our other speakers will talk about, access has to do with cost. And a number that I think we just need to remember about this proposed bill is 25-25-100. That would be a $25 copay for insulin drugs, $25 copay a month for non-insulin drugs, and $100 maximum copay a month for equipment and supplies to treat diabetes. So I'll share that on the chat box, and just thought giving that big picture would be helpful to people. And I will pass the microphone along to Maggie Ryder. Thank you very much.
Hello, thank you for having me here. My name is Maggie. I'm a teacher in Montague County Schools, Morgantown, and I have a son that's a type 1 diabetic. He was diagnosed at the age of 6. Back when he was diagnosed in 2008, his care every day required that I sent to school with him test strips, a monitor, lancets, crackers, juices. By the time he graduated a year ago, because of the Freestyle Libre, he didn't need any of that anymore because he was more controlled. His A1C went from, it was a 12 to a 7. The problem with this is, as a teacher, my paychecks would go solely to the care of the insulin and the Freestyle Libre. I don't want to cry the poor mouth, but teachers don't make a lot of money. I was a widow and my son had to work at the age of 16 to help buy the Freestyle Libre. So he said, it's worth it to me to help pay for it because, and I'm quoting him exactly, diabetes is hard enough on a person that they deserve a hassle-free and easier health option that will take care of him the rest of his life. So I ask you to please consider legislation that will make this stuff easier on the checkbook of average people like me. And let's change lives. Thank you.
Okay, our final speaker is Gary Doherty from the American Diabetes Association. Thanks, Maggie.
Hi, I'm Gary Doherty, and I am the Director of State Government Affairs for the American Diabetes Association in West Virginia. As Jeanette said just a few moments ago, about 15% of the adult population in West Virginia have diagnosed diabetes. And there's another 45,000 or so who have diabetes, but they don't even know it yet. And just as startling, or perhaps even more startling, is the fact that more than 500,000 West Virginians, more than a third of the adult population, have prediabetes with normal blood glucose, with higher than normal blood glucose levels, who, if they don't make lifestyle changes, particularly in their diet and their exercise regimen, they may later be diagnosed with diabetes. And as we've talked today, and as you probably already knew, the cost of insulin is out of reach for many. And that's why insulin affordability is a priority for the ADA. As Delegate Fleischhauer mentioned, legislation was passed last year to cap monthly copays for insulin for those on state-regulated commercial health plans, as well as public employees through the Public Employees Insurance Agency. West Virginia is a leader. West Virginia was the 5th state to pass this type of legislation. There are now 13 states plus the District of Columbia that have passed similar insulin copay cap laws. However, as we've talked this afternoon, more must be done. The legislation that Delegates Fleischhauer and Rohrbach are sponsoring seeks to address the high costs of some non-insulin drugs, as well as equipment and supplies that are needed to manage a person's diabetes. Connecticut was the first state to enact this type of legislation last year, and the American Diabetes Association looks forward to supporting this effort here in West Virginia and expand on the success that we had last year and make diabetes drugs, equipment, and supplies more affordable for West Virginians living with diabetes. I will turn it back over to Delegate Fleischhauer.
Thank you. Thanks to all of our speakers. Thank you very, very much. And Jessica, I think you have been working on the questions, if there are any.
I am looking right now at the chat. I'm not seeing anything coming up. If somebody does have a question, please unmute yourself and.
Yes, we are all from Morgantown, the speakers. No, most of us are. Some of us are from Huntington and Charleston.
From Cabell.
Okay.
Yeah, we've got,
I have a question. Can anybody hear me?
yes, we can.
Yes.
Okay. Actually, it's for Delegate Fleischer and
Rohrbach.
Rohrbach. Okay, yes.
Okay, so we've got Aaron.
Sorry, my
Question.
thing is echoing, but so I'm gonna take my earphones off right now, but I was actually on the caravan last year where we went to Canada, and I saw all the effort that it took to kind of get the last bill passed. So how important do you think it is to have bipartisanship for this bill that you're going to be presenting in the legislative session this year? It's for either one of you who are a co-sponsor for it.
Well, it's very important in my opinion. I mean, good health policy is not a partisan issue. In my opinion, this needs to be an issue as all health matters that the legislature can all coalesce, because it improves West Virginia's health, economy, well-being if we have a healthier population. So to me, there's no partisan divide on health issues.
Yeah, and I just have to say I agree with my colleague. This is a critical issue. It was a bipartisan issue in Connecticut. In fact, one of the interesting things, I spoke to a representative today who led the charge in Connecticut, and they have a Democratic supermajority. The Republicans, like Matt, have a Republican supermajority, and they, I think he told me I don't know where I have my notes on that, but they have a larger House than we did, and there were 4 people that voted no, 150 some voted yes. But it was a very big, the Speaker, the Senate President, and the minority leaders both were sponsors of the bills in Connecticut. Connecticut is really the center of the insurance industry. And so I'm very encouraged that we have a decent chance here. And I'm very pleased that Matt has agreed to be a sponsor on this bill. It's hard to pass any bill in 60 days, but it's much easier if you have bipartisanship.
Thank you, Beth.
both.
I think, and thanks, Aaron, for asking. about that. That's such a good question right now. I wanted to say we've got Taylor Stuck has a question. Or if you would if you want to unmute yourself and go ahead and ask.
Yeah, hi everyone. This is Taylor. Two questions really. A follow-up to that. Have you, Delegate Fleischhauer or Matt, have you spoken with leadership about this bill and where do they kind of stand on it? Were they interested? And then I was also wondering if the federal had anything to do with if you took that into consideration at all. Obviously, the Trump administration's order has been rescinded while the Biden administration looks it over, but are you keeping an eye on that, and will that have any impact on this bill?
Well, I have spoken with leadership about it, and I think this bill is going to get a good hearing. I'm certainly, as Vice Chair of Health, I'm got a little influence to try to get it moving, but again, I think this bill is going to get consideration.
Taylor, thank you for that question. I have spoken with I'm keeping people informed on the Democratic side. We haven't had as many conversations on the Senate side. Obviously, we can't pass something without it being approved of by the leadership in both houses. But are you saying that the Biden administration rescinded the order relating to insulin and Medicare? Is that the one you're referring to?
Yes.
Okay.
Or put a memorandum on it, put a hold on it at least.
Oh, okay.
I have a little information on that. This is Alan Hawkins.
Thank you.
Go ahead, Alan.
I read in National Law Review that, again, there was a hold put on. Trump, what he talked about was not going to happen until January 22nd. I know he mentioned earlier on that it was as cheap as water. Well, the faucet was off. And now with Biden looking at it, it would be interesting to know what's going to happen with that. I talked to local pharmacies here, and a lot of the companies now have basically the same insulin in a generic form, and it's about half the price. In other words, for the pens, instead of paying $500 and some dollars, it's about $275. But still, that's pretty daggone high. And so, yeah, I would like to know what Biden is going to do, but your bill should not interfere with that because it has a broader range with capping copays that are more affordable. And it deals with a variety of products.
And Taylor, our bill, we can only cover things that are not covered by federal law. So our bill would cover like PEIA, it would cover managed care, I think a lot of that, and private insurance companies. And so a lot of people, like one of the women who came with us on the bus, she was covered under Medicare and we couldn't really help her. So what the Trump administration did was very important, and I hope we can build on that with the new administration, but it's not something we can affect.
Thank you.
Thank you, Taylor, for asking a question. Are there any other questions out there for our panelists for this press conference today on these diabetes supplies and their affordability? I don't
have a question. I just wanted to say that it was really nice to hear everyone's story and everyone's take on this, and I'm just really happy to be covering it. So thank you.
And Aaron,
Thanks, Aaron.
If you need any more information, you've got Barbara, you've got me. We've never met, but meet me.
Okay, yes.
Of course, yes. Let's connect. But anybody else on here, I'm sure they would be happy to share with you too, if you need more information. Is there anybody else on the call that has any questions?
I'd like to bring everybody's attention to what Gary just posted in the chat,
What?
which is the ADA.
I'm sorry, I'm on a Zoom right now.
About the pause. Gary, can you give us any more information about what the ADA is thinking about the pause? You need to unmute yourself.
It's really very similar to what Alan had indicated. The Trump executive order wasn't going to go into effect until next year. And I don't have I just sent the link, but I don't have the actual statement in front of me. So I would encourage you to take a look at the statement. I do recall that it's not meant to be a punitive thing to the diabetes community. So take a look at that. And if you have any questions, reach out to me. And if I can't answer them, I can get some folks from ADA who can respond to the questions.
Well, if there aren't any more questions, whoa, now it's a really long thing in the chat.
Oh, that's from Kat.
What were you going to say, Jesse?
No, that's just a message from Kat about the Medicare plans.
So Kat, do you want to explain that? I was wondering if do you want to unmute and give us the
Yeah, hi, Barbara.
quickie version?
Sorry for the long.
No, that's fine.
Can you hear me okay, Barbara? I have minimal internet connectivity today. We had a lot of snow here in the Eastern Panhandle. I was just saying that the pilot program that President Trump trumpeted, is sort of been pulled back, actually was fairly limited and had a number of issues with it. It sounded great on the surface, but it was really quite limited. It was run through the Medicare Advantage plans. Only certain plans could opt into the program, and you actually could see your premiums go up for one of those Medicare Advantage plans with the insulin cap. So I was just posting that. I think there's a quicker, easier, better way to get the job done, and that's with this state legislation.
Great, great. Okay. Well, I see that you're there, Mike Nolting. Thank you for joining us. And thanks to all the media and all the people that helped us organize this behind the scenes. And we look forward to having help trying to get this through both houses of the legislature. It looks like Matt had to disappear. It was very nice of him to take a little break from his patients to be with us today, but we will wind up then. And thanks to everybody, and please stay safe out there today and every day.
Thanks a lot.